Welcome to Surro Talks, a weekly podcast where Kevin, a father of two through surrogacy, and Petra, a former IVF nurse and fertility consultant, unwrap all the aspects of your egg donation and surrogacy journey. Join us every week to discuss various topics around surrogacy and egg donation.
On episode 4, we are joined by Dr. Chloé Roumain, a fertility doctor specializing in reproductive endocrinology and infertility, the founder of the Tripod Fertility Clinic in Toronto, and the co-founder and president of Fertility Friends Foundation, a registered Canadian charity that provides grants to couples accessing fertility treatment. Dr. Roumain walks us through the many steps of the IVF process for both egg donation and surrogacy, from the initial consultation all the way to a confirmed pregnancy.
So welcome everyone. This is our 4th episode of Surro Talks. Today, Kevin and I are joined by Dr. Chloé Roumain from Tripod Fertility. Thank you so much for joining us.
My pleasure.
So today we're going to...
Thanks for having me.
Yeah, we're so happy. Thank you. We're going to be discussing the medical aspects of your egg donation and surrogacy journey through IVF. So please, if you have any questions throughout, we can take your questions at the end, but we will keep watch of them. And Kevin, why don't you help us get started?
Sounds good. So, one of the themes that we've been talking about throughout this series is the importance of creating your team when you're going through a journey like this. And obviously a big part of that is the medical team you're going to be working with, whether it's your doctor, the nurses, the staff. So as a medical professional, when you meet your patients for the first time, can you talk us through a little bit about that initial meeting and what to discuss? What types of questions your patients should be thinking about asking you, and what you're looking to get out of them as well.
Okay, yeah, no, absolutely. If you're okay, I'll start with maybe egg donors first, and then we'll go on to potential surrogates.
Sure, absolutely.
So for egg donors, the first consultation really focuses on making sure that we go through the medical history and really making sure that there are no contraindications to that person going forward and becoming an egg donor. So first, do no harm in medicine, and in this situation, this is an elective and altruistic procedure. So we want to make sure that there's no reason not to do the procedure. So we go through a very thorough medical history, all the person's background, personal medical backgrounds, surgical, as well as family history, just to make sure that there are no conditions that would go against going through an egg donation cycle. And what we're looking for are usually things that will prevent you from being able to take the hormonal medication. So things like blood clots, liver condition, kidney condition, etc. Usually our egg donors are young people, and so it's rare that we'll find something, but it's important to be thorough. We also go through habits, lifestyle, so smoking, drinking, drug use. We prefer a clean lifestyle, specifically smoking. Drinking, definitely light drinkers is okay, but definitely not through the cycle, and drug use ideally to avoid. And so the medical history really focuses around that. The other part of the first consultation is also to discuss what are the tests that we're going to prescribe to this person. So what can they expect? What's coming up? The tests, the purely medical tests they're divided into blood work and radiology testing. So the blood work is infectious screening, and then blood work to look at general health, so things like anemia, a small workup, as well as fruits of the problem, which is the ovarian reserve. So sometimes donors will come with this information already. They've done these tests before because they've donated or because through an agency they've done them. But otherwise, those are the tests that we would prescribe. And then radiologically, we would want a pelvic ultrasound. So to look at the pelvic organs, the uterus, the ovaries, to see, again, here, two purposes. So one, is there a reason not to do this procedure? So is there a big cyst, a big fibroid, something that we need to know about that prevents us from going forward and that this person should know about for their own medical history? But also we want to see the ovarian reserve. So we're doing the ultrasound to look at the ovaries and look at the presence of the follicles that are there. So that basically the first consultation will revolve around that, what we're going to screen for and the questions that we're asking.
Great.
For the egg donor.
Yeah. And what about for the IPs, so intended parents? What kind of questions do you find they come to the table for that initial session? Do you find they've got a lot of questions about the whole process? How do you try to guide them in that initial discussion?
So with the IPs, it's really quite variable because their journey can be so different. So it could be patients that we've known forever, and they've tried with their own gametes, their own egg, own sperm, and it hasn't worked. Mm-hmm. And now we're moving on to an egg donor. So we've talked about things as we've gone along, like as things have failed, we've talked about this being sort of plan B, plan C, and it's moved up the list as unfortunately their cycles haven't worked out. So these types of patients, they know a lot more about how it's going to work because they've done IVF, so they understand that the egg donor will go through an IVF cycle and have the eggs harvested. So they know a lot more about the process. If we have a family who needs egg donation because of another reason, let's say same-sex male couple, then they haven't gone through that process. So they need to understand what this person is going to go through. So we really take them through an IVF cycle, basically from the point of view of the donor and the tests that she will have to do and the procedures that she'll have to undergo. So it's very different depending on the type of family and the journey that's preceding the egg donation. Mm-hmm. That makes sense.
Absolutely. And so when IP is looking at an egg donor, I think age is a big factor in this case, correct?
Yes, so we do have a sweet spot. Too young is not great. So some people will say, oh, if someone is 20, like she would be an ideal donor. But actually, what we see is that under 25, a lot of times our donors do less well than mid to later 20s donors. So we would prefer. We're not. I mean, we will work with donors of a younger age, but I'm just saying in terms of, in general, what we find is that younger donors sometimes won't do as well as we'd expect. So they will get less eggs, respond less well to stimulation, even though they're in their very fertile years, or the egg quality won't be that great. So basically, a better window is between 25 and 35. But again, sometimes we'll have a family coming with wanting to use a specific egg donor because of genetic relations. So somebody wanting to use their sister, something like that. And that person is 37. We're not going to say, oh, no, you're not 35. So we can't, it's obviously it's a case by case depending on what the situation is. But this person has to be a decent donor, right? Because if we're going to go through this whole process, including for the donor and for the IPs, we want to have interesting results. We don't want this to be futile. So if the ovarian reserve is really low, obviously we're going to advise the parties maybe to go with someone else, or at least that they'll know they may not get a lot of eggs or embryos from the cycle. But the good guide is 25 to 35, I would say.
I just want to touch on that point of the number of eggs you're going to retrieve through the process. Do you have that discussion with IPs in terms of what to expect? Because I guess there is a really big range in terms of what can happen when you go through the egg donation process, and nobody really knows until you do the procedure. Right.
So we can guide. So we can because we're going to do testing on the egg donor, so we're going to have some numbers to work with. So we'll have the AMH, which is a blood test, anti-mullerian hormone, gives us an idea of egg reserve of number, and the AFC, which is the antral follicular count. That's done. That's measured by ultrasound, and it's a count. Like it's an actual count. We sit there and count the number of follicles that we see early on in the cycle, around day 3 usually, and that gives us an idea of how many follicles are sort of in the race for that month. So if we do nothing and you have your regular cycle and you ovulate that month, these eggs are sort of competing with each other, and then one will get selected for ovulation because it responds better to the hormones, because it's better quality. That's the one that's chosen that month, and the others are suppressed, and your body gets rid of them. So with IVF, we make sure that we try to get all of those eggs to move forward instead of having one and the other suppressed. So when we see that number, we can give an idea to the donor and to the IPs, of how many eggs we can expect to get. But you're absolutely right. Sometimes things don't go as planned. So it is a range. And we do say, it's going to depend on how the person responds. But it can give at least a range.
Great. And now when it comes to the surrogate, I guess there are different factors that you are considering, correct?
Right. So the surrogate, so the age range would be a little bit different. So we, because we're not talking about egg quality, we can often go, we do go with older surrogates, older than 35, because in this case, we're going for, so the person will carry the pregnancy. So we like to talk about 45 as sort of an upper number, but again, I don't want to say that that's a strict number. If there's a candidate that is older than 45, in very good health and is an excellent medical candidate, we're not going to refuse someone because they're above the cutoff. But it's sort of where we like to operate. We go through medical history, same as the egg donor, but we're looking for medical conditions or surgical conditions that would contraindicate having a pregnancy. So we're looking again to do no harm. So things that can get worse with pregnancy, so high blood pressure, diabetes, again, kidney conditions, heart conditions, etc. And these can be present, and we want to be able to counsel or even say, no, you're not a good candidate and you shouldn't do this. We obviously want to go over gynecological and obstetrical history. So has the person had pregnancy before, have they carried? What did that look like? Did they have a premature delivery? Did they have a stillbirth? Did they have, preeclampsia, pregnancy-induced high blood pressure, etc.? So that gives us a little bit of background. How did they do previously in pregnancy? But we don't require in our practice, so in my clinic, we don't require the gestational carrier or the surrogate to have carried before or have had a pregnancy before. A lot of places do, and there is a rationale behind that. So as I just said, we'll have some medical history, you'll have some background. You can say, well, she carried, she did very well. She had twins and delivered at term. This is a great indication that, that pregnancy went well, especially a high-risk pregnancy, etc. But it doesn't mean necessarily that the next one will be completely normal. So, and then it doesn't mean also that if you've never carried, that you will not do well. It's just that we don't know. The other reason is that it's more of a part of the counseling and the psychological aspect is that if you've never carried before and then your first pregnancy is a surrogacy pregnancy and it's a baby that will go to IPs that you're not keeping, is it better that you've completed your family and you don't want any more children? But again, that's putting judgment on the person's ability to make a decision, and some people don't want children, and so you're going to keep this whole group out just because this person's never carried. So for all those reasons, yes, of course, there's benefit in having that medical history, but we don't rule people out based on the fact that they haven't carried before. But again, you do get that history if the person has had pregnancies before. Again, there we want to look at lifestyle, medications, anything that the person is taking that can be a contraindication, and also that shouldn't be used during pregnancy. So sometimes there's medications that have to be changed before the person can go forward. We do sort of ask about, let's say, how many children the person wants. If they already have one, let's say, and want more, and they've had a C-section, again, they have to realize their chances of having another C-section is high with this pregnancy, and this is a surrogacy pregnancy, and then if they want more children, then, that adds to the C-section number. So these are the types of discussions that I have with gestational carriers or with surrogates when they may want more pregnancies after and there's a C-section. So things like that are all discussed.
Is there a limit to how many times somebody could go through a surrogacy as a GC?
I mean, again, I don't personally decide that unless there's a medical reason, right? So if there's, let's say they had their placenta was implanted into their C-section scar the last time, and it was very difficult to remove, and they bled out, and they had this complication, I would say, this medically, I would not recommend being pregnant again. But unless there's a medical complication, something that would indicate having another pregnancy, I don't have a number where I say you cannot do this. That definitely doesn't come for me.
Yeah.
Unless there's a medical reason. In terms of testing for the surrogates, sorry, I forgot to complete that. We usually want to, we definitely have blood tests. So for infectious screening, health screen. And then we also usually do either a saline sonogram or a hysterosalpingogram. So radiological testing of the uterine cavity. So to see if there's anything in the uterus that would prevent good embryo implantation. So that's the main test that we want to do for a carrier.
Great. My next question, I think we've already touched on. So Petra, do you want to take it for the IVF portion?
Yeah, absolutely. Would you be able to give us an overview of the IVF process?
Absolutely. Yeah. So we're talking about egg donor then at this point.
So starting with egg donor and then moving to the transfer with the surrogate.
All the way to the transfer. Okay. So if this egg donor has made it to this point, that means that they've gone through the testing, we've worked with donor, they've had the ultrasound, we've counseled them, and they've also gone through, as I mentioned before, some clinics will ask for drug testing. Some clinics will ask for carrier screening. So I think later on, maybe we can talk a little bit about genetics, but I'll go through the IVF cycle at this point. But basically, you've been cleared medically and all the other tests, and you're started. So we do an ultrasound at the beginning of the cycle. So day 1, day 2, to have your baseline. And if they look similarly to the ultrasound that we did for screening, we have a good number of follicles, there's no cyst, there's nothing to prevent from starting. The donor will start her injection with her hormonal medication. So we usually bring people back day 5 or day 6. So from the beginning to day 5 or day 6, they're taking their same dose at home, so injectable medication that they administer either themselves or somebody in their surrounding will inject for them. And then they will come in day 5 or day 6 for an ultrasound and blood test to see how they're responding. So it'll be a pelvic ultrasound to look at the ovaries and the uterus and see what follicles are growing and how the lining is looking in the uterus. All of this tells us response. And the blood test will be done for estradiol, or E2, as it's commonly called, and LH. So the hormone that precedes ovulation. So we want to make sure that the donor is not going to ovulate on her own. So we want to see where that number is. If everything is responding well at this point, typically around that day is when you will add a medication to block ovulation. Because at that point, the follicles are growing, the hormone level, the estradiol level is going up. So you're risking ovulating on your own, and that's what we don't want, because we want to go get those eggs when they're ready. So we'll add another injection to block ovulation, and that's the antagonist medication. This is if you're in that type of cycle. So in this cycle, there are other types. They're used a little less, and they're almost never used for donors. So I'm not going through them. I'm going through the antagonist cycle. And then from that point on, people will come back every other day, or even every day. It starts becoming closer. And each time you come in, same thing. We have blood work and ultrasound. We evaluate the response, and then we contact the donor at midday to tell her what to do next. So does she keep the same dose? When does she come back? So each time, that's the procedure. By the time that we have the response that we're looking for, we're usually around between day 10 and 13, 14. It could be longer, but usually it's around there. And what will happen is that what would be the number of follicles that we're looking for. So good response, somewhere at least around 10, 12 eggs, but we could have as many as 20. We don't want to overstimulate so that the donor doesn't get sick without hyperstimulation, but we want a good response. So somewhere between those numbers is a good place to be. And usually we'll see a good hormone level that will correspond to this number of follicles, because the follicles are producing this hormone. So it should match, the number of follicles we see should match the hormone. And once we get to that point, we know that we have the response that we want. There's going to be one last injection to do, and that's the trigger shot. It's commonly known as that, and it's also administered the same way under the skin, usually in the belly area. We pinch a little skin and inject right below the skin. And 36 hours later is when the egg retrieval is going to happen. So usually that last shot is given in the evening, so that 36 hours later is 2 days later in the morning. And that has to be timed very precisely so that we don't go too early or too late. If you go too early, eggs won't be mature. If you go too late, you may miss it and the patient ovulates and you don't get anything. So it's a very important shot. And when we talk to donors, and our nurses do a great job of this is where you really want to hammer things. The timing, doing the injections properly. Are you injecting in the right spot? Are we getting the response we're looking for? If we're not, what's going on? What's wrong? Is she not responding? Are the meds stay out and they were supposed to be in the fridge? What's going on? And then, but that trigger shot needs to be religious. And then 36 hours later, the donor comes in, and the procedure is called the egg retrieval, and it's done under sedation. Sometimes we need a bit deeper anesthesia. It depends on the history. If somebody has had a lot of pain before from the procedure, we may do a different sedation. But usually, sedation is what you use. So you come fasting, you have an IV put in, and you have medication injected through the IV to help with relaxing and to help with pain management. So you're sleepy, you're relaxed, but you're not under anesthesia. It's not general anesthesia. So we can call you, you wake up, but usually you're sort of sleepy or in and out. Some people are more awake. It really depends on the person, but hopefully you're comfortable. And then we get started with the egg retrieval. It's usually done with pelvic ultrasound transvaginally, but sometimes we have to do it abdominally. So through the belly, again, guided with ultrasound and a needle. And we go into each of those follicles we were talking about before. So the little sacs that have our eggs inside. And with the needle, we aspirate each one at a time, and they go into a tube, which is given to the lab directly. They look in the tube and in the liquid to see if they find eggs. And we empty all the follicles that we can safely empty. And then at the end of the procedure, it takes about half an hour. Sometimes it's faster, sometimes it's longer, depending on technical difficulty. And then the lab will tell us how many eggs we got at the end. So at the end of the procedure, we know how many eggs. And then later on, we know whether they're mature or not. But at least we'll have an idea of number by the end of the procedure. And then the egg donor goes for recovery. So there's a recovery period where we make sure that anesthesia wears off, that side effects are dealt with, nausea, things like that, pain. And then once it's safe and okay for her to leave, then she can leave. She has to be accompanied because she's had anesthesia, so she can't drive. So usually people will, if they're alone, there are services that exist that can accompany egg donors to come pick them up, things like that. Or if you have someone that comes with you, then you go with that person. Or sometimes people leave in a taxi, but they have to be accompanied if they can't drive. So that's all the way till the egg retrieval portion. From that point on, the egg donor is not in the discussion anymore. So at this point, she is recovering from her procedure, but isn't privy to what happens to the eggs and the embryos after that, because then it becomes the IVs are it's their embryos at this point. So unless there was something medical that happened with the egg donor, obviously we disclose, but otherwise there's no communication unless it's open, obviously, unless it's not an anonymous donation.
Mm-hmm.
And the embryos would get created right then after the retrieval, correct?
Sorry, it cut off. The embryos get created that day?
Yes, correct.
Yes. So now moving on to, so at this point we have eggs. So on that day, either if there's an intended father or if there is an a sperm donor, we have a sample on that day, and fertilization happens. So embryos get created, so the eggs and the sperm are put together in the lab, and we will know the next day how many fertilized. And there's two ways to fertilize them. So either they're put together and natural fertilization happens, or standard IVF, versus ICSI, or intracytoplasmic injection of sperm, where the sperm is injected inside the egg. And there are different indications for doing that. And I think I don't think this is kind of the scope of this talk, but you will hear those terms. And it just depends on what your physician will recommend or the lab will recommend for particular patients. And so fertilization will happen, hopefully, because there can be lack of fertilization, but hopefully it happens and you get embryos. And then there's a new countdown that starts, because up to this point, we were counting day 1 to day of retrieval from the cycle of the donor. But at this point, it's day 1 or day 0 is the day of the retrieval, and that's the age of the embryos. So day 0 is retrieval day, and then day 1, the next day, is when you find out how many fertilized, and the embryos are 1 day old at that point. So what usually happens is then the lab communicates with the IPs to give an update of how these embryos are growing. Typically, you have day 1 update, so you know how many fertilized, and they look for signs of the two nuclei, one from the sperm, one from the egg, being present, and signs of fertilization, and then usually get an update day 3 and usually day 5. Some labs don't give an update on day 3 and leave the embryos and don't disturb them, if you will, but most labs will give an update day 3 and then day 5. So on day 3, the embryos are graded, and what you usually hear is you find out how many cells they have, and somewhere between 8 and 12 cells is a good place to be. And you get a grading based on how those cells look. Are they symmetrical? Are they fragmented? Do they look, now nice and round and all the same size? So the grading will be about those features, which are subjective. The embryologist looks at them and gives this grading. Then day 5, at this point they're called blastocysts, and they have a lot more cells. And the reason they're called blastocysts is because there's an area of fluid that forms in the embryo. So the cells organized on one side and the other, and there's a fluid-filled area, and that's where the name comes from. So at that point in time is when they are usually ready for transfer, but there are transfers that happen day 3. It depends on, again, not the scope of the talk, but why would you need to transfer day 3 or day 5? Most often we do blastocyst transfers. So the embryos are cultured all the way to day 5, and then sometimes they're cultured longer, so day 6, because sometimes at day 5 we don't see the signs that we're looking for a mature blastocyst, so we push them another day, and sometimes even day 7. If there's additional testing to be done on the embryos, it's usually done when they're at the blastocyst stage. So it can be done starting day 5. And I know we wanted to talk a little bit about genetics at some point in the talk. So pre-implantation genetic testing is done at this point. So this is the biopsy, right, that happens on the embryo. So you can go in and you take a cell from the side that's not going to become the individual, but the side that will become the supporting tissue, so placenta, fluid, etc. And those, you take a few cells and they're sent off for genetic testing. Now, what you have to understand is that there are different types of testing. So usually the PGT-A, you're looking for correct number of chromosomes. So is there, are we is the embryo euploid or aneuploid? So it's a number of chromosome question versus PGT-M, which is another test that is done at the same time, but that would be looking for a specific gene abnormality. So let's say the family, there's carrier, someone's a carrier for cystic fibrosis or sickle cells or whatever else, and you're looking for a specific gene, then that's what you need to be looking for at that point. So very different goals in terms of what you're testing for in the embryos.
And so just to help people kind of connect the dots a little bit, this used to be called PGS and PGT. Correct. Okay.
Yeah, so pre-implantation genetic screening is what it used to be called. Exactly. So you may still hear the term. Now it's more specific with the PGT-A and yeah.
Perfect. And since we're on the topic, when do you recommend PGT-A?
So it's a tough question because, we talked before about donors being at an ideal age for donation, so under 35, and the idea there is to look for people who have a good ovarian reserve, but also people who are less likely to have aneuploidy or abnormal number of chromosomes in the embryos that will result from their eggs. So female age, we know, is important in terms of risk factor for this. Definitely aneuploidy goes up after 35 and much faster after 40. So by keeping our donors younger, we reduce that risk. It doesn't mean 100%. Obviously, some embryos will have genetic abnormalities no matter what age you are. That can happen at any time. The question of whether IPs should do it, definitely if you're using a donor that is 38 or older, I would definitely recommend it. In the case where I talked about before, where you may choose a donor that's older because you want someone who is related to you, or you want a specific person, and so you're going with an older donor, and then I would recommend it for age at that point. The other reason to look at PGT-A is you're looking at a situation where you're gonna, let's say you're going to use a surrogate, okay? Then there's a cost issue, there's a time issue, there's a commitment and investment issue. You want to optimize your chances. You want to optimize the chance that it will work the first time, or that that what embryos you're putting in, so that you can make a better selection. So it's not 100%. There are limitations to PGT-A, definitely not the scope of this talk, but at least if you have this information, this extra information, and you know that these are, good quality embryos, you increase your chances of it working, or you give yourself an extra bit of information to be able to select embryos. But again, if you have a young donor, and you're still going to have your grading of your embryos, so they're going to be graded with a number and a letter when they're at the blastocyst stage, and it's still going to give you an indication of the embryo's quality. We didn't have genetic testing a few years back, and we still were able to transfer, best embryos first and whatnot. So you can definitely not do it, and it's not a bad decision, but it is an extra bit of information in case, let's say, it doesn't work. If you didn't test the embryos, you may not know why it didn't work. Mm-hmm. But if you test and you're putting presumably euploid normal embryo in and it didn't work, then you know what else could be wrong, and maybe be able to optimize things. So it's good for the detective work if things don't work, and it helps with selection. But again, it's not a must, because your chances are going to be very good if you have a young donor and the grading of the embryo is very good. May still not work the first time, but it's your chances are good because of the age and the quality that you're seeing. So it's a depends question.
Can you tell us a little bit about what, just like high level, what an abnormal embryo may mean down the line if we unknowingly transferred an abnormal embryo? What could that mean?
Usually, most likely what will happen is that it won't implant. If it's that abnormal, it won't have the prerequisites to be able to interact with the lining of the uterus, and it just won't implant. Or it'll implant and it'll miscarry quite early, or a little bit later, like all the way to 8 weeks, but first trimester, let's say. If it's very, very abnormal, it's quite rare that it will develop further along. So most likely, what will happen is that the pregnancy will not be viable and it won't progress. If it does progress, so if it's an abnormality that's compatible with life, so something like Down syndrome, trisomy 21, then that will be detected a little bit later on into the pregnancy. We have tests that we can do quite early on. Prenatal testing you can do as early as 9 weeks through a blood test. So you would still do that test even if you had. It's still recommended to do these tests, to do nuchal translucency at 12 weeks, and look for signs of aneuploidy or of abnormalities. So if the pregnancy does go farther forward and you do find out that there is a genetic condition, then the counseling happens at that point, knowing what are the risks, what does life look like if you have this condition, and then the parties invested have to make a decision whether the pregnancy goes forward, whether termination is an option, whether this is not compatible with life. What do we do? But if it's a severe abnormality, usually it won't implant, or it'll be a very early loss, unfortunately. But that's the way sort of nature protects these embryos from going forward.
Right.
And just a quick question here. Even though you may have an embryo that has been deemed normal, you can still, in certain cases, the embryo can develop an abnormality throughout the pregnancy. Is that correct?
100%, yes, because we're just talking about aneuploidy or a problem with the number of chromosomes with this test, with the PGT-A. So with pregnancy, you can have structural abnormalities. So you may have a heart defect that develops that has nothing to do with genetics, or any organ or any sort of malformation that's not genetic can still happen. So it does not guarantee a normal pregnancy, but it really looks at number of chromosomes, which is the number one cause of early miscarriage or of non-implantation. So that's the issue there. That's what you're looking at.
Right.
All right, thank you. So taking it back a little bit, so we have done our IVF cycle, we've created embryos, and now we are ready for the surrogate part of the medical process. So can you tell us a little bit about how the surrogate will prepare for her embryo transfer and then moving forward from there?
Yes. So where we left off with the embryos, so they'll be frozen at this stage, so day 5 or day 6, depending on how far they were pushed in the lab, and whether they've had the PGT or not, they're frozen at this point. Now, when a surrogate starts her cycle for embryo transfer, or frozen embryo transfer, FET, which is one of the terms we'll hear, you'll hear us say, you can either do a natural cycle or a medicated cycle for the surrogate. So what happens often is that our surrogates are not in the same city as we are. They live where they live, and we work with them. So it's often easier to do a medicated cycle, because for a natural cycle, we'd have to follow their natural menstrual cycle. They would come in and we would do blood work and ultrasound to try to see when they're ovulating, to catch that moment, and then from the ovulation on, we would transfer the embryo on the 6th day after the ovulation. So that has a lot more follow-ups involved, blood work and ultrasound, and they have to come in more. So it's a lot more difficult if you're not in the same city or if you don't have access to monitoring where you are. But it can be done, and it has less medications to take, but more screening, more ultrasound, more blood work. A medicated cycle begins when the surrogate gets their day 1, their period, and they take some form of estrogen, either by patch, by oral route, or vaginal, can be given, and they usually take it for about 14 days. and we bring them in for a lining check. Sometimes we'll have them come a little bit earlier. It depends if we have experience from a previous surrogacy journey and they know when they're usually ready, but 14 days is a good reference. They come in for what is the lining check. So that's done through ultrasound. And we look at the inside of the uterus, so the lining, and you'll hear people talk about it. It's trilaminar, so we see 3 lines, the top, the middle, and the bottom, and we talk about the thickness. So the trilaminar is it looks, and then the thickness is the thickness. So we're looking for 7 is sort of the sweet spot millimeter, but it can be a little bit less, 6.5 ideally or more, and then we don't want too thick either because we may wonder, is there a polyp there? Is there something going on? Why is the line so thick? So 1.4 sort of upper limit, but again, it depends on how it looks. If we can see through and it doesn't seem like there's a polyp, but it's on the thicker side, we may go forward. But that's kind of the range that we're looking at. If we have the lining that we're looking for, the aspect and the thickness, then the second part of the medication can start, which is the progesterone, and that can also be given through injection. They're painful injections, they're through the muscle, so those are more painful than the IVF injections because those are under the skin. So very brave patients give themselves these injections for many weeks. It can also be given vaginally, and sometimes we do a combination of both. So 1 injection, 2 vaginal, 1 injection. It depends on the protocol. And that's something that is talked about at our subsequent meetings. So we talked about the original consultation with surrogate or donor, but once they've cleared and they have their follow-up, when I talk to them about what I'm planning in terms of a protocol, we talk about all these things. We talk about what they're going to take, what are the side effects, how are they going to administer, how many days, etc. And then our nursing does education session, and they also talk about it with them. But I'm sure that I do as well. So then the surrogate will take the progesterone for 5 or 6 more days. Again, there's some testing that can be done for the window of implantation. So sometimes this surrogate has tried in the past, and we know that they're ready a bit later. So it may be, on the 7th day, depends, but usually it's 6. And then some places will do a progesterone level, so blood work to check for progesterone level to make sure that it's in the right range and that they're absorbing it properly. And then on the day that the transfer is planned is when the surrogate comes in for the embryo transfer. Doesn't need to be fasting on that day. They have to come in with a full bladder. So that's the hard part on that day. No anesthesia. It's not a surgery. It's done with a spectrum. It's not gynecological. It's bladder is very full, and there's ultrasound guidance. That's why we need the bladder so that we can see. And we use a small catheter that goes inside the cervix. It has the embryo inside, and the embryo is deposited at a certain distance from the back of the uterus. We see it go in live. Everyone can see it. Sometimes the IPs are in a different city, but they can call in and be present. And it's a very magical moment every time. It never gets old. And then the wait starts. So embryo is put in. We always check the catheter, make sure it's empty. So the embryo was actually put in the uterus, and then the waiting starts until the pregnancy test.
And when is the pregnancy test after the transfer?
It's usually 12 days later, but a lot of people will test at home before. We know most of our kids do, and you often will get a fake line before, but it's important to come in for that blood test. Some medications that you may have been on, if you did, for example, a natural cycle for your embryo transfer, and we gave, for example, HCG to trigger your ovulation, you may have HCG in your blood that you took from medication, and HCG is the hormone that we look for pregnancy, so it may confuse the test. It's more rare that you've taken that, but it's important to come in for the blood test so that we have a number, because the urine test at home is a qualitative test, so it's a yes, no, but the blood test is quantitative, so we get a number. We have an HCG of 103, let's say. So that is important for us, because if it's very low, it tells us something, and then we can get ready and we can cancel based on that. So important to still come in for the blood test, which is repeated 48 hours later, and we like to see that it doubled, but it can increase by a bit less than doubling, and that doesn't mean it's bad. But that's the sort of the key word would be, did it double? And we follow it. Depends on the clinic. Some places will do another one. Depending on where that second number is, we may stop at 2 measurements. But if it's not increasing as we like, we want to continue to follow it. But if the increase is satisfactory and we know pregnancy is established, then the next step is the ultrasound for viability. And that's between 6 and 7 weeks to be able to see if we have a heartbeat. You have an embryo and a heartbeat.
And just for the beta HCG test, what type of numbers are you looking for? Just so parents have an idea of, what those numbers might mean.
Like I said, I don't think it's, you shouldn't think that a certain number is bad. For sure, there's some, suspect it's a bit low, this might not go well. We like to see it above 100, but it can be lower and still pregnancy goes very well. So again, it shouldn't be, the be all and end all, but. Yeah.
All right. And then that last part is ultrasound, as you mentioned, and from there, what's going to happen after you see a viable pregnancy on that ultrasound?
So usually, so that's around, like I said, between 6 and 7. We tend to do it more closer to 7 weeks to be sure that we've reached that point and what we should be seeing on ultrasound. Because the worst thing is to do it a bit early. You don't see what you should be seeing, and then everybody gets worried. But it's actually normal. It's just that it's early. Whereas 7 weeks, you should be seeing this, and this, and definitely a heartbeat. So you know that if you don't, then it's not normal, right? After that ultrasound, usually we do one 2 weeks later, so we do 9 weeks. Again, for viability. We should see progression of the size of the embryo accordingly, and it should measure for the number of weeks that we're expecting. And then after that, it's the prenatal testing, ultrasound. So usually when you do the nuchal translucency, and that's done between 11 and 14 weeks. We usually do it at 12, just to be in the middle. And at that ultrasound, yes, we want to see the thickness of the nuchal fold, because that's associated with some aneuploidy, so things like Down syndrome or other chromosome issues, but it can also be associated with heart conditions, kidney conditions, other malformations, as we were talking about before, that may or may not be genetic. And then at that ultrasound, we also can see quite a bit of anatomy. So we do look at what we can see at that point. And then depending on the clinic, most fertility clinics don't follow patients past that point. Some don't even do the nuchal translucency, so they'll do 7 week, 9 week, everything is viable, is okay, and then off you go with your gynecologist or your family doctor or midwife, whatever follow-up you're planning to have. At our clinic at Tripod, we do prenatal follow-up as well, so our patients can stay with us for the duration of the pregnancy. So we continue on, but some of them, they're from another area or they already have their doctor, so they leave. But most of the time they'll stay until the 12 week, so that when they leave, they've done sort of, they're feeling, more relieved at that point.
Amazing.
I
Well,
feel like
thank
you need a big
you. That
glass
was
of
a
water
lot
before
of
that.
information for everybody to digest. No, I
Great.
mean, it's absolutely perfect.
It's funny, I've had about 12 flashbacks to our own pregnancies, just listening to you talk about the different procedures, and it just brought back a whole bunch of memories.
I'm sure. Lots of stress, but a lot of happy moments as well.
Yeah, and it's amazing how much you forget about all of it. When you're living through those procedures, it becomes your life on a day-to-day basis. And it's
You know
amazing.
the numbers. You know exactly what the lining was.
Yeah, and it's amazing once you have your children with you, it just becomes a really distant memory, which is great as well, right?
Absolutely, yeah.
Well, thank you so much for your time today and all the knowledge you shared with us. I hope a lot of people found this valuable. And
I hope so. I was very, very happy to be a part of this. Thank you for having me.
We're taking a little break next week because it's the long weekend in Canada, but we'll be back in 2 weeks with Michelle Flowerday to discuss the legal aspects of surrogacy and egg donation. So, again,
Excellent.
Dr. Roumain, thank you so much for your time.
It was my pleasure. Thank you so much for
Thanks so
having me.
much for joining us.
Thank you.
Please
Have a
like
great
and subscribe to our
See you in a couple
channel, and
weeks.
we hope to see you next
Bye.
week.
Bye. Bye.